It is my honor to introduce the Academic Senate Faculty Research Lecture. This award recognizes exceptional career achievement in clinical research. The Senate will also host the Faculty Research Lecture in Basic Science later this spring. Nominations are made by UCSF faculty who consider scientific research contributions of their colleagues, and they submit nominations for this prestigious award to the Academic Senate Committee on Research. Every year, the Committee on Research selects a recipient for the award, and I'd like to thank the committee for their hard work. Today, we are proud to honor our colleague, Dr. Nisha Acharya. Now, I'm pleased to introduce Dr. Acharya's nominator, Dr. Jackie Duncan, MD, PhD. Dr. I mean, that's a lot for that PhD. Dr. Duncan is a distinguished professor in ophthalmology and is the chair of the ophthalmology department, and she will introduce Dr. Acharya.
Thank you, Jeannie. Thank you. I don't have a PhD, set the record straight. I am so excited to be here today with my co-nominators, Dan Lowenstein and Tom Lehman, both of whom were excited to nominate our wonderful colleague, Nisha Acharya, for the UCSF Academic Senate Faculty Research Lecture in Clinical Research. And we're so pleased to be here introducing her for this incredible award. Let me tell you a little bit about Nisha Acharya. Nisha is, in my mind, the exemplary definition of a clinician-scientist and a mentor, which is what this lecture is really meant to recognize. We really don't take enough time at UCSF to sometimes stop and appreciate all the incredible contributions of our faculty. And Nisha is really an example of the very best of what UCSF can be. Nisha is the Elizabeth C. Proctor Distinguished Professor of Ophthalmology and Epidemiology and Biostatistics. She has a faculty affiliate appointment in Global Health Sciences. She's also the Associate Director of the Francis I. Proctor Foundation, Vice Chair for our department's Faculty Development and Mentorship, and she is also the Director of the Uveitis Service at the Proctor Foundation. This is where it all began. Nisha was always as beautiful as she is now. At a very young age, Nisha was born in Wilmington, Delaware, to two immigrant parents. Her father was a pharmaceutical chemist who came to the United States for graduate school. Her mother was a high school chemistry teacher. They moved around some, including a time in Fort Worth, Texas, when her dad was working, I think, at Alcon. Yeah. And then she went to junior high school and high school in the Chicago area. Then she went to Stanford for undergraduate degree in biology and a master's in health services research. She came to UCSF for medical school and then the Brigham and Women's Hospital for internship, followed by ophthalmology residency at Massachusetts Eye and Ear Infirmary. We were fortunate to recruit her back to the Francis I. Proctor UCSF Foundation for a fellowship, Francis I. Proctor Foundation and UCSF for a fellowship in uveitis. She spent a second year of fellowship doing a research fellowship at Genentech to learn more about clinical trials. And shortly after that, she joined the faculty where she has been ever since. This is a photo of Nisha with her parents and her brother, who is 3 years younger. And this is when they're younger and a little bit older. So this is, as I summarized a moment ago, Nisha has excelled at every step of her career. She has been absolutely exceptional. She was named to the Phi Beta Kappa Academy at Stanford. Honor Society at Stanford. When she was at UCSF, she received the Regents Scholarship. She was a member of Alpha Omega Alpha, and she received the Janet M. Glasgow Memorial Achievement Citation, as well as the Sadie Burkove Award. During her postgraduate training, her exceptional performance continued. She completed her internship at Brigham and Women's, and then during her residency, she received the Harvard Medical School Teaching Award at Massachusetts Eye and Ear Infirmary, and then completed her cornea uveitis fellowship at Proctor, followed by a clinical research fellowship at Genentech. This is not the whole story of Nisha. Nisha's outstanding exceptionalism is not limited to science and medicine. She is a concert violinist. In junior high and high school in the Chicago area, She was performed in the Chicago Youth Symphony Orchestra. She was the valedictorian of her high school class, and she really loved everything, but was mostly very passionate about music, studying violin very seriously at Northwestern University during high school and playing with the Chicago Youth Symphony Orchestra. She then applied to Stanford on kind of a whim because she wanted to see the West Coast, and we kept her when she came. She had never visited before began her undergraduate training at Stanford. She played in the Stanford Symphony Orchestra as well. And then in the UCSF, she played in medical school and the Brigham and Women's. And then she also has more recently been part of a UCSF orchestra as well, which I'll show you a picture of in just a moment. I want to just take a moment to say when I was asked about Nisha's application for this award, they asked a lot about her mentorship. And this was an easy one for me because she serves as our vice chair of mentorship and development. But she has also won awards for her mentorship at UCSF on 3 different occasions. And this is just a little comment from one of our current interns, Annika Kumar, who may be in the audience. Thank you, Annika. So these nice things. And this just really, in my mind, really summarizes how exceptional Nisha is. So Annika said, as I reflect on my medical school journey, I'm deeply grateful to Dr. Acharya for constantly inspiring me. I think that Nisha has this influence on a lot of people. Working with Dr. Acharya has been transformative, and I'm lucky to look up to her as a role model. Seeing her in action as a renowned clinician-scientist has really opened my eyes to this career path as a possibility. She has single-handedly equipped me with the tools to feel empowered to pursue it. Nisha's drive to cultivate the next generation of researchers is evident in her approach. She constantly challenged me to push beyond my comfort zone while providing just the right amount of guidance to foster growth. Through every stage of the research process, Dr. Acharya offered thoughtful direction that nurtured and strengthened my critical thinking and creativity. Thank you for that, Nisha. That resulted in one of many mentorship awards that Nisha had. She serves as really a leader in the field of clinician scientists and academics. So she has served on so many different roles. She was the secretary of the board of managers for the AUPO Fellowship Committee. She's been an oral board examiner for the American Board of Ophthalmology. She served many roles in the American Uveitis Society, has run the Uveitis Subspecialty Day meeting at our annual American Academy of Ophthalmology meeting, as president of the American Uveitis Society, and has worked to standardize nomenclature of uveitis through the Uveitis Nomenclature Working Group. She works with American College of Rheumatology. She also works with Pediatric Eye Disease Investigator Group, the Pediatric Uveitis Planning Committee, and currently she's serving on the Intelligent Research Site IRIS Registry Analytics Committee, looking at data from all over the country to inform how we take care of patients. She has served on NEI study sections and has been a reviewer for Research to Prevent Blindness grants. She is an incredibly accomplished clinician scientist with over 39 international invited presentations, 110 national invited presentations, over 243 publications in the peer-reviewed literature, including top-notch journals like JAMA Ophthalmology, JAMA and Lancet, as well as Ophthalmology. Her work has been cited over 12,000 times. Her H-index is 62, and she has had continuous funding from the NIH since 2005. She's had almost every grant that I think there is. She's had all of them. And she has had so many honors and awards. She was a Genentech postdoctoral research fellow and received an award for that role. She has received career development awards from Research to Prevent Blindness, an achievement award from the American Academy of Ophthalmology, as well as her senior achievement award from the American Academy of Ophthalmology. And then at least 3 different times has received UCSF's Dean's Mentorship Awards, both short-term mentorship and long-term mentorship awards. And this last year, she was honored to receive the 10th annual C. Stephen N. Francis Foster Lecture on Uveitis and Immunology at the American Academy of Ophthalmology meeting. Furthermore, she will be delivering the Mildred Wiesenfeld Award for Excellence at this year's Association for Research in Vision and Ophthalmology meeting. This is a national award that goes to the top-notch research in the country. And this was named for Mildred Mosler Wiesenfeld, who founded Sight. And near to my heart, Wiesenfeld campaigned for 50 years to increase funding for eye research because while she was losing her own vision to retinitis pigmentosa. So, as I mentioned, Nisha is a concert violinist and has been one since a very young age. This is a more recent picture of her performing with the UCSF Strings Collaborative, a conductor-less student-run string orchestra. And more importantly than everything I've just said, Nisha is the loving, devoted mom of two adorable and accomplished and brilliant children. This is Mia, who is 15 years old and a prolific composer, and Avi, who can fix anything. He's also a computer whiz. He spent some time at the Proctor and got into very deep conversations with Travis Porco, sitting in the back row over there. And then finally, Nisha is a foodie. She loves to cook. This is a recent demonstration of her Valentine's Day cookie bake-off at Proctor. And I think that she tied for first place with her shortbread cookies shown in the back of the table. So she is an incredible cook as well. Nisha's work is not only important and has an outstanding and well-funded, it has had an incredible impact on the field. So Nisha had quite a journey this year where her very well funded, very well rated, very highly regarded NIH grant was abruptly and without any good reason discontinued. Her research grant mentioned vaccine hesitancy, and then it was terminated for a period of time, which generated a tremendous amount of attention to this issue. Nisha was featured in the Washington Post, San Francisco Chronicle, CNN, and the LA Times. And I'm pleased to say that because Nisha showed a lot of resilience and appealed this decision, and her grant was restored later in the year 2025. So congratulations, and that's a happy ending to what was a very tumultuous development. So please join me in welcoming, it's enough out of me, please join me in welcoming Dr. Nisha Acharya. We're so proud to congratulate you on giving the Academic Summit, Dr. Research Lecture, Small Field, Big Data, Advancing Evidence for Ocular.
Thank you, Jackie. I couldn't almost bear to hear that. That was really very special. Thank you. I am extremely honored to be here today. It's almost it's hard for me actually. You know, I give a lot of talks, but I've had a lot of emotion in the past days, and especially today, thinking about being here and what it means to me. I'm extremely grateful for this opportunity and just want to thank the Academic Senate and to Dr. Duncan, Jackie, for thinking about this, for nominating me. I was kind of floored when when it happened, and the co-nominators, Dr. Dan Lowenstein, who's here, Tom Liebman, the director of Proctor. It's just at every step in my career, I've had individuals just pull me up and really keep me going, honestly, and just show me why, I'm so lucky to be where I am, and inspire me to do more and to do better. And all three of these individuals who are here in the front have done that for me, and that's why I'm here today. So thank you. It's a huge honor. So my talk is entitled Small Field because I am an ophthalmologist who takes care of patients with a relatively rare disease. But my goal is really to do better for our patients. That's really what drives me every single day. I'm a clinician-scientist doing clinical research. Jackie talked a little bit about my background. So I'm going to pick up from my medical school time. Actually, I got to where I was to college and medical school because my family was amazing and allowed me to kind of discover my own passions, never forced me or tried to tell me what to do. I had a very, extremely open, I would say, life and being able to explore my passion. But then, I came out to California, and like she said, I had never been out here before. I never even had visited with my family or anything. It was kind of on a whim, really, that I applied. And after Stanford, I came to UCSF because I had heard so much about UCSF and the values here, and it really resonated with me. And I was really fortunate to be here. I was just talking to Dan Lowenstein about this. We don't have a lot of photos from, it was 1996 when I started. So 30 years ago, I was a medical student here. I started medical school, right? And I finished in 2000. And I would have dreamed that I would be standing here 30 years later giving this lecture because I was in awe of people like Dr. Lowenstein.
our favorite professor for, I would say, for generations of medical students, honestly. Would say, if we had to identify who had the most influence, who was our go-to faculty during medical school, it was definitely him. It was during my time, and I keep on hearing that. But that was the times, right? It was 1996, and I was so lucky to be here. I had a lot of mentors, including who taught us both in the classroom and in the clinic, both. So it was 4 years. But beyond that, really just was just someone just to talk about life. Like he would ask about how are we doing? And that has continued through this. Like today I saw him and he's asking about my family. This is who he is. And he's done this through every stage of my career now for 30 years. And, it's very special people like that. And so I just want to say thank you for being here. Michael Drake, Dr. Drake he was on our faculty. He's still now back on our faculty in the Department of Ophthalmology here, and he was one of our deans. And I was that I had supported him in medical school as well. I mean, how can you ask for more amazing mentors, really, and leaders? And so I would say, being here, I'm so lucky as a medical student to be exposed to and to be able to work with people who are very open to even a medical student, a first-year medical student. I don't have a lot of photos from medical school, but I found my graduation photos of a bunch of us have been used in a lot of promotional materials. And I have these promotional materials, even though this is decades ago. My graduation photo, I don't seem to have a real one anymore, but I have a promotional material in UCSF alumni magazines. So, but yeah, so I want to just, from there, let me just talk about kind of what happened during medical school. I loved everything. I loved every subject. I liked psychiatry. I liked OBGYN. I liked neurology. I loved medicine. I liked everything. And I didn't know what I wanted to do at all. And I think if I reflect back, it was just a series of experiences that really got me into what I'm doing today. And it was just random, kind of fortuitous. But it kind of just shows you in life how things can happen that can just really put you on a certain path. And so for me, what happened is that during my first year of medical school, we had these small group sessions in our physiology course. I know the curriculum's changed, but we used to have physiology, and then we had a vision or eye section. And it was taught by Emmett Cunningham, who was a faculty member at the time in the lower right-hand corner. And he is a uveitis specialist. He's no longer here, although he's still affiliate faculty and teaches. But he was teaching our small group section. And I was not thinking ophthalmology at all. I had no idea about it. But he in his section, he talked a lot about it and about global health research, and he was doing international research. And because he was doing uveitis, he was doing research like HIV in the eye, and it was tied to the rest of medicine. And I love that. And he said, if anyone's interested, you can come talk to me. I have opportunities for summer research between first and second year. And he said that during our small group section. And so I went and met with him. And I started working with him. And that summer I worked at San Francisco General. I still call it that. And I did research on HIV and got to the clinics, and I loved it. And, it was because he said in section, come talk to me. And then I continued to work with him, and he introduced the Proctor Foundation as a medical student. This is the old building at 95 Kirkham, is in the fog all the time, but I still love. And now we're in this building, which is beautiful, and I love it here too, but it was a special place, even in the fog. And I continued to do research and had a lot of opportunities to do that as a medical student. Jack Witcher, who is on Zoom listening, as a professor emeritus, and he was a proctor at the time, supported me. Made it possible for me to do a research project at Aravind Eye Hospital, which you see on the bottom here, which is this amazing eye care system in India, the largest eye care system in the world. 2/3 of the care is free there. It's a sustainable eye care system. They do eye camps and really bring in patients from all these surrounding villages who need eye care and provide a lot of free care. And I studied leprosy in the eye, actually, of all things, but it was really amazing, and learned how to look at the ulnar nerve and, all of that, and the effect on the eye. He made it possible for me to go and arrange my trip, and I'm really grateful to him. And then, Todd Margolis, who then became the director after him, and then Tom Liebman here of Proctor. I got to meet them a little bit as a medical student. I didn't work with them directly, but I got to meet them. And in my mind, I realized what an amazing place this was here for ocular infection and inflammation. And that stuck with me. And I'll come back, but these were the individuals that I met very early on during my medical school years. And I went away to Boston. When I was in Boston, I don't know if you remember Dr. Lowenstein, but you and Dr. Drake were out there. You were at Harvard and you took me out to dinner. I was an intern and a resident, and I mean, you were so, you're leading all these institutions, and you found me, and I remember that. And I have a hard copy photo somewhere. I just got to find it, but really, I have it in my head. It was just a beautiful memory of, again, continued mentorship and leadership. And so I had a great residency there, but I was drawn back here for fellowship, right? I had met everyone here and knew that interests, which were ocular infection, inflammation, this was the place to be, both for research and for also clinical care. And so I was lucky to be back here, and several people have been very influential during that time. So Tom Liebman became director of Proctor 10 years ago now. And so after Todd Margolis, and really was, the fellowship director and then director of Proctor, huge influence, probably he's my research mentor, right? He's the one who taught me everything about how to do the kind of work I do, how to do international clinical trials, how to be a rigorous methodologist, how to be kind and generous and always a better listener, and gives me good feedback to this day. I really think at every stage, you got to have somebody who's honest with you and tells you, what you can do better, what you can do differently. That would be him. So I think I'm really grateful to have had him from the beginning as my key mentor, and throughout, even as I lead my own research programs for many years now, I go to him when I have challenges. And then the Department of Ophthalmology, we've had two great chairs during my time here. Stephen McLeod, who was amazing chair, who made us have this building. Honestly, that's why we're here, because he did this. And so we're lucky because of him. He has a huge legacy in everything that he did for us in ophthalmology, and is now CEO of American Academy of Ophthalmology. And then his successor, Jackie Duncan now, who's been really equally amazing in terms of looking out, I would say really looks out for all the faculty and has grown the faculty, committed to the academic mission of research and clinical care and teaching. And also the Department of Epi and Biostats. I was part of the K Scholars program early on, and this was the first year of that in the CTSI when Steve Hawley was running it, and many other folks some of them are no longer with us. Amazing mentors across all disciplines. And that was what's amazing about UCSF, is that it was great for ophthalmology and for what I was doing, but it's the whole university that's the strength and the people, and I benefited from that. Some photos from my early years at Irvine Eye Hospital with Steve McLeod. I think this is it's a long time ago. I don't have dates on all these. These were hard copy photos. At that hospital, you do everything. You examine abdomens, even as an eye doctor. You look for TB and nodes, and you do everything. I learned to operate. I don't operate anymore as a uveitis doctor, but we're in cataract surgery. Jack Witcher is down here in the bottom. He started the micro lab at Irvine Eye Hospital, and I kid you not, it's not a joke there. He and Vicky Savalos, who was a microbiologist here at UCSF for many years, they bled the sheet to make the blood auger there. Really, it's true. It's not just myth, it's incredible. And now it's a really amazing micro lab that does, full state of the art, but that's how they started. And on the right, you can see a young Tom Liebman. I'm in the middle here, and it's in front of the uvea clinic. Tom does cornea, and I did cornea research with him, corneal ulcer research in my K, but I love that this photo is in front of the uveitis clinic, because that's what I do now, and I love that. And I don't know how we ended up in that clinic years ago, but somehow that was a sign. Okay. I'm going to move on to the research in a minute, but I want to just say how proud I am of both the Proctor Foundation, which is an organized research unit, and Department of Ophthalmology under both Jackie and Tom, really amazing leaders. We're not a huge department together. I think 70-ish faculty something like that, maybe a little bit less. So pretty small, maybe 60 to so faculty, but we've been in recent years one of the leaders in NIH funding together with Proctor and the department. We've been ranked #2, and departments are 3 or 4 times larger than us, are ranked way below us. So for a very small, medium-sized kind of department, this is a testament to the commitment to research and the academic mission and UCSF to make this possible. All right. Okay, so I'm going to now switch gears to what I do and my journey a little bit into some of the things that we've done. So this is a photo. This is of an eye from a patient. This is what uveitis can look like in the eye. I'm going to say a word about what uveitis is because it's a weird word, right? It's maybe something that a lot of people, even doctors, don't always know about. But you can see there's inflammation in the eye here. There's white blood cells that are depositing on the back of the eye. Those are called chorotic precipitates. It's a sign of inflammation happening in the eye. Normally, the eye is an immune privileged site. There is no inflammation. It's kind of this unique organ, but things can happen where the immune system, kind of starts essentially attacking the eye, and you have inflammation in the eye. So it's a very serious group of conditions. It's not just one condition. Uveitis is a group of conditions that affect the eye and affects the middle. It really stems from the pigmented middle layer of the eye that carries blood to all the other parts of the eye. So the iris, ciliary body, and the choroid are part of the uveal tract. And normally, you have this ocular barrier and all the white blood cells stay in the vessels. They don't go into the eye, but that's lost when you have uveitis. So the uvea is the uveal tract. It's grape in Latin because it's all these layers, and then itis is inflammation. So basically inflammation that stems from the uveal tract and then can involve any part of the eye. That's what uveitis is. We don't know what causes it. Just like so many other immune conditions, it's probably many different things in the world, right? There's so many triggers we all have, exposures to the environment, microbiome, maybe some genetic predisposition. But in any case, there's this immune dysregulation that results in inflammation in the eye. And sometimes it's in conjunction with inflammation in other organs like arthritis or kidneys, brain. And sometimes it's just eye limited. Sometimes it can be in conjunction with infections like syphilis or tuberculosis or shingles. We never really find a cause in more than 50% of patients. We don't find anything else in the body, but we still have ongoing inflammation in the eye. It is relatively rare. We don't have great data on this, but it affects about 1 in 1,000 people in the US and maybe more in other countries that have more infections. But most uveitis is non-infectious. Anyone can get this, any age, any sex, any race, anywhere in the world. But unlike a lot of other ocular conditions that affect more older people, this is more common in working age adults, in ages 20 to 60. So that means there's significant ramifications in terms of lost work, productivity, economic ramifications. And this condition accounts for at least 10% of blindness in the US and other developed countries and more in the rest of the world. And that's thought to be an underestimate. So it's a pretty, it can be a very devastating disease because inflammation in the eye damages the eye. Show you some photos of what we see when we examine patients with uveitis. So you'll see these are so heterogeneous, right? But these are all patients who have inflammation in their eye, and you can see the damage that's happening in the front of the eye and in the back of the eye, collections of white blood cells. All of these are non-infectious with the exception of the bottom right is a patient who has syphilis and those spots in the retina. All of these can cause blindness. More pictures here. This is a non-infectious, basically autoimmune attack of the retina here, and you have all these spots. And you can see that over time, there's more spots happening. And so it can be a chronic progressive disease. Another example, and even more here, you see over time progression of scarring, all from the immune system, right? It's this kind of really crazy, fascinating, but also devastating condition for patients who have it. And it can affect the retinal blood vessels. This is retinal vasculitis. And what I love is that what I really loved about this field is, I liked all of medicine. Remember, I didn't want to give up anything. And for me, being able to do this field means that I can see what's happening in the eye, but still think about the rest of medicine, right? Because I have to always think about, is there something else going on in the body? think about, and I talk to patients about it, we always go on that search to try to find out what's happening. And so I feel like it's kept me in the loop, in terms of really thinking about the whole body and what's happening and not just the eye. Retinal vasculitis. All right. So as a clinician scientist, I'm a lab scientist. What can I do, right? How can I contribute to helping patients with condition? The biggest area for me that I was able to really focus on is how do we treat uveitis? And and I think I quickly realized when I was starting in this field is that we don't have a lot of data. We don't have evidence. It's in these rare diseases, this can happen where there's not much guiding us. And so, we sometimes feel like we're doing trial and error medicine. And that's just the reality. There's just not much to do. It's often based on, the principle of eminence, right? Like, oh, this worked for me, so I think it's the best treatment. I mean, that's honestly, and things have improved over time, although I would say we're still behind in our field. But that also meant that there was an opportunity, right, to be able to contribute and to be able to advance our evidence and do research to contribute to our evidence basis to be able to hopefully take better care of our patients. So uveitis is often recurrent or chronic, not a once and done kind of thing, right? It can happen over and over again or be chronic where there's always progressive damage. And for years and years, and even now in many places, what's happened is that uveitis is not treated on a more chronic basis. It's treated intermittently. The problem is if you treat when you see kind of big flare-ups, each time you have a flare-up, you're accumulating damage in the eye. And you end up with this cumulative damage over time and then vision loss from all that's happened in the eye. So we don't really like this whole thing, this whole idea of doing intermittent local therapy or even intermittent steroid therapy. It's still done so many places around the world and even in the United States. But that's not the way that we really want to be treating a chronic condition. So what do we want to be doing? Well, we want some sort of long-term therapy. And we do have sustained release steroids, but those carry huge complications like cataract and glaucoma. We don't have any other type of local therapy that's a non-steroid right now in our field. It doesn't exist. So we are usually nowadays looking towards systemic immunomodulatory therapy. And these are, as our understanding of the immune system improves, there's been a huge increase in availability of different drugs targeting the immune system. And they're not designed for inflammation, but they exist. And so we have those available to us. Hard to get, but that's what we do nowadays. That's our preferred treatment is systemic immunomodulatory therapy. If you look at the evolution of uveitis treatment, I mean, most of it's really only been this century or maybe the late 1900s or 1990s when we started using medications that are, acceptable from an immune standpoint, have decent efficacy. Really before that, it was really empirical herbal therapies. And in the 1950s, huge deal to even just have steroids. I mean, that was life-saving, but also vision-saving for people. But as we all know, being on steroids long-term is also devastating. But that was all we had. And then alkylating agents, which were great, I mean, in terms of being able to control inflammation, but can cause cancer, cause infertility, it wasn't great. And we're getting into the era of anti-metabolized calcineurin inhibitors, biologics, and that's kind of the era that I, trained in and I've been practicing. And we're fortunate to be practicing in this area, but we don't have, I would say, evidence to really know how to use these therapies effectively and what works well. We're sort of just trying things in that class. So all of these, agents work on different parts of the immune system. Methotrexate and mycophenolate, azathioprine, those are the antimetabolites. Those are go-to first-line drugs for eye inflammation. And for patients where that's not satisfactory, we're moving more into the biologic era where we have more targeted therapy. Someday those might be first line, but they're not yet. So one of the first questions that I faced in practice, many of us face, is which immunomodulatory therapy should be used first in chronic non-infectious uveitis? It's just a practical question. Like, what do we go? We need to be on something. We can't be on steroids forever. We need to be on something. And so it seems so basic, but there was a lot of controversy with this simple question in the field. And this is why. So until June 2016, we had no FDA approved non-steroid drugs. for uveitis. And then in June 2016, adalimumab, which is known as Humira, commercially got approved. But before that, there was nothing approved. But you have all these other agents available, but they were all off-label. And we had no clinical trials on them. But by and large, antimetabolites like methotrexate and mycophenolate that are widely available around the world were being used and still are being used as first-line therapy. But all we had were non-comparative retrospective studies to guide us. And what did they say? Well, if you look at the studies, really all of them, most of them, I think, if not all of them, showed that mycophenolate mofetil, which is also known as Cellcept, was better than methotrexate. It worked faster, and also more efficacy for uveitis. And the thing is, we can't necessarily use data from other autoimmune conditions. They don't necessarily extrapolate to uveitis. There's many, many examples of drugs that work for arthritis, like, for example, etanercept or Enbrel, that don't work for eye inflammation, don't work for inflammatory bowel disease. So diseases are not all the same, all autoimmune conditions. But this is what the prevalent thinking was in uveitis. And there's pretty big differences from retrospective studies in terms of the efficacy. But these are non-comparative. The patients were not randomized. And if you look back at these old studies, the methotrexate dose was always very low in those studies. And I think that was because people were scared to use higher doses of methotrexate. And the mycophenolate they thought was, maybe a more tolerable drug, and those were high doses. So you saw this big imbalance in these studies where mycophenolate looked better, but they were using them at much higher doses and methotrexate was underdosed. So, I wanted to just do a trial on this. I thought this is a very practical question. Let's do a comparative effectiveness trial to compare these two drugs. And Tom Liebman had taught me you can't just apply to NIH and just expect to get funded for a trial, just because you have an idea. You have to show that there's interest in the field, there's controversy, that it's feasible, that you can do it. And so the steps of doing surveys and showing that there's differences in thinking, doing pilot studies, these are the steps you have to do before you can then say, I should get NIH funding, I deserve it, or I am ready. You have to show that you've done all these steps. And so I did a survey of American Uveitis Society, and MMF is mycophenolate mofetil. And, it was clear that uveitis specialists really preferred it. If costs were not an issue, they would prefer to give mycophenolate mofetil. And that was probably just because of the because of the retrospective studies showing that it works better. But cost was a lot more for mycophenolate. I'll show you, it's like maybe 3 to 5 times more than methotrexate. And costs vary depending on insurance, but because these are off-label, meaning not FDA approved, patients often have to pay for them. And this is even a bigger issue in other countries, right, where there's not insurance in many places and patients have to pay. Many uveitis specialists insisting that their patients pay for mycophenolate because they thought that it was a better drug because of these retrospective studies. And they were insisting on making their patients pay this every month. And so we did a pilot study, and I did the pilot study with Dr. Rathanam from Aravind Eye Hospital, just one center, just to show feasibility with working with them. Proctor had done a lot of trials at Aravind, California, but we'd never done anything for uveitis. And we did a small pilot study of 80 patients, and it wasn't designed to show a difference between drugs, but we found that methotrexate looked a little bit better. It was 69% treatment success versus 47% in mycophenolate. So that was interesting. It's not what anyone thought in the field, right? And we did a high dose of methotrexate in this trial. We went for 25 milligrams, which is the high dose. And so, found a result that was not honestly different than all the retrospective studies. So with that, we were able to get funding to do a more definitive, multicenter trial funded by the National Eye Institute to do the FAST trial. First-line antimetabolites, a steroid-sparing treatment, uveitis trial. And it was a comparative effectiveness trial to compare methotrexate mycophenolate for uveitis, and the endpoint being corticosteroid-sparing control of uveitis. And then secondly, we wanted to look at if you failed one of the drugs that you were randomized to, what happens if you switch to the other antimetabolite? Is it useful? Does that make sense? Are you likely to succeed with that or not? Because in real life, this is what people were doing. They were trying multiple drugs, and is it a waste of time or not? So that was the second part of the study. And so we did the study over about 5 and we finished and published our results in JAMA in 2019. You can see there's authors from all around the world, and I just wanted to say how that happened. So, the pilot study was just at Irvine Eye Hospital. And then when I put in the grant application to do the FAST trial, it was going to be across the US at a few centers in the US and India. Irvine is an amazing eye care center with multiple different hospitals, and they did a great job in the pilot. And so we thought with the US centers and them, we could do this trial. But then right when we were about to start in 2013, we got a letter from the NIH, from HHS, saying that we can't enroll in India because there's new guidelines that really make it, these rules were regarding liability in clinical trials. They had nothing to do with our trial. They were really related to things that had happened in trials related to HIV, actually. But basically, because of that, the government put all these rules on, on liability and trials. And so the US government was not comfortable funding any research in India actually involving patients. So this was a bad moment for me because I had worked many years at this point to try to get this grant and was excited to do a uveitis trial. There was no uveitis trials. And then here we were, and this was going to be like, more than half the patients probably would have been in India. So this was a moment where it kind of reminds me of this book called The Splendid and the Vile by Erik Larson. This book is about Churchill's, so Winston Churchill's first year as Prime Minister of Britain, 1950. It was during the Blitz, in London. There was bombings every single day. It was a terrible time. That's the vile, horrible time in history. And everything was kind of apart. And despite that, Churchill, the good and the bad of him, but in any case, he was able to have the country come together and have resolve, just to kind of be able to still persevere, really. And during hard times, he really helped the country come together and find some moments of joy, actually, and resolve to overcome all the hardship. And that's the splendid. And so, what do you do in those moments where something doesn't go well, right? So I was fortunate. NIH didn't pull my grant. They could have said, well, sorry, you can't do this. But they said, figure out another way. We'll support you. You can still have your grant funding. And then the uveitis community is just amazing because it's small, right? There's maybe 200 to 300, not even, maybe 200 something uveitis specialists in the US. And, there's not that many in the world. They care about science. We know there's a lack of research. And so people from around the world came together, and this is NIH-funded research, so they do it in the interest of science. And we were able to expand our network of collaborators. And this really, a very diverse patient population at this point, ranging from Mexico to Saudi Arabia to India to Australia, like all over the place in the US, to do this trial. But it worked. And it was a randomized trial, observed masked comparative effectiveness trial, 216 patients. And it was a homegrown operation. We shipped out all the meds, we did all the training on the site, trained all the coordinators, tons of site visits. John Gonzalez, who's here, helped me so much, and tons of site visits to all these countries. I did a lot, and I couldn't possibly go all the time. And I'm really, thankful that he went to check up on things as well, many, many times. And so patients were randomized to methotrexate mycophenolate. They all got a prednisone taper that was standardized because these drugs take a while to work. And our treatment success was basically being able to taper the steroids down successfully and controlled inflammation in all parts of the eye. We did a lot of work with defining endpoints for uveitis, which is something that hadn't been done a lot, both by imaging and on exam. That was a novel area on how to really have good endpoints for these kinds of trials. Still a work in progress, I would say. But basically, this is what we found. So we found that at our primary endpoint of 6 months, 67% of patients who received methotrexate were a treatment success versus 57% the mycophenolate group. So 10% favoring methotrexate. That was not a statistically significant difference, but that was still meaningful to us. It was a negative trial in terms of having a statistical significant difference, but this was still really remarkable because everyone thought that mycophenolate was going to be really superior. And some of the sub-analyses on pre-specified subgroups were significant in terms of favoring methotrexate. I'm not going to show that here, but there was a lot of data also favoring methotrexate in the pre-specified subgroup analyses. But at the very least, overall, we have a pilot trial and we have a kind of multi-center trial showing that, that there's not a difference really, that there's not a statistically significant difference. And if anything, methotrexate looks a little bit better. And we didn't really see much in the adverse events. Methotrexate was associated with, did have a little bit more liver function abnormalities. It was expected, but they were mild and recovered, and very few serious elevations. So this was reassuring. And this result continued when you looked at sustained success. About 80% of patients continued to be able to have controlled inflammation at a year. So they were controlled at 6 months and at a year. And what we found is when you switch, if you failed methotrexate, you're not going to respond to mycophenolate, versus if you failed mycophenolate and you switch to methotrexate, you will. So more data supporting the use of methotrexate for this type of uveitis. And we've, and so we've done a lot of work, kind of deeper dive using the data and the imaging from this trial. And a lot of fellows and students, residents have been able to have worked on this, including one of our fellows, Ahmed Reddy, from a couple of years ago. He's now faculty at University of Colorado. One of the things is we wanted to look at is what predicts failing both drugs? Because why should you spend a year trying methotrexate and mycophenolate? It takes like 6 months to really see if each drug works. And then at the end of the day, neither works and you have to move on to biologics. And the big thing we found is retinal vasculitis does not respond to these drugs. And there's a white paper now actually in the field saying that we should go to TNF alpha inhibitors or biologics early as first line for retinal vasculitis. It's a big change, because why do you want to spend a year with a devastating kind of form of eye inflammation if it's not going to respond to these drugs? And so it's important, even though the success rate's overall pretty decent with these drugs, and they both are pretty comparable, there are certain characteristics, or certain features that maybe don't respond as well. So that's important to know. And we've been able to, thanks to so many medical students and trainees and research analysts, do a lot of work on this, looking at quality of life, looking at CD4 counts, looking at macular edema. And I just want to say, I think bringing in trainees into your research is like the single best thing I've ever done, because they think of great ideas. They put in 100% effort. They, of course, are, they keep me on my toes and help me to think about new things. And I think we're much more productive when we work with trainees. And so I'm very thankful that I've gotten to work with so many. So in summary, for the FAST trial, it might seem like a basic kind of thing, but I think there's pretty clear evidence now that the more expensive drug is not superior. And given that, around the world, I think we feel comfortable that we can use the cheaper drug as a first-line therapy. And I think the approach of starting high, I think the reason we found a different result is we went with high-dose methotrexate. And we found that it was pretty tolerable. And if not, you can lower the dose. Instead of this strategy of starting really low and then trying to creep up, we think it's been a practice change for most people now, is to go pretty much to the high dose right away. And I just want to thank, this trial was funded by NIH, and all of our investigators around the world really made it possible. At Proctor and UCSF, the primary biostatistician was Travis Porco, who's here. John Gonzalez, my uveitis faculty colleague, Tweed Dewan, also enrolled many patients and helped with this trial. And Jeremy Keenan, who's faculty here, is a medical monitor. We had so many amazing trips to train everybody and to really form collaborations around the world. It's like the United Nations. This is in the Med Sciences building. If you look at you can just tell looking at it, it's kind of an eclectic group of people from around the world. But I love that, right? It's just people who had never been to the US, even some of these coordinators. But it was amazing to everyone was so dedicated. Yeah. And so now I want to switch gears to another condition that I care about a lot, which is pediatric uveitis, and specifically juvenile idiopathic arthritis, or JIA. I take care of patients from all ages, from babies all the way to older people, and I care about all of them. And they're all challenges we have with all eras of life, or all stages of life. But I think there's special challenges when you have children, because you have the child, you have the family. It's very devastating to families to hear that their child has this chronic inflammatory condition and, could lead to blindness. And so I think I really feel we want to do as much as we can for that population. And I think about 20% of my clinic is pediatric, actually, at this point. And so I see a lot of these patients. This is a condition where the eyes look pretty white. They don't look red. Patients don't feel pain, but there's this ongoing chronic eye inflammation that happens progressive over time that can cause blindness. And so it's often missed. But it happens in conjunction with juvenile idiopathic arthritis, which is the most common rheumatologic condition in children. And about 20% of those kids can get eye inflammation that's chronic. We have so many targets for arthritis, and we use them for uveitis as well. But one of the go-to drugs now is adalimumab or Humira. And this is a human monoclonal antibody to tumor necrosis factor alpha. It is FDA approved in the last decade, a little bit less actually for JIA, but it got approved for uveitis about a decade ago now. And it's been shown to be effective for JIA and JIA uveitis. Very expensive drug, responsible for huge healthcare costs, which is an issue. Biosimilars now, but still, Humira has a huge part of the market share. Biosimilars are very expensive as well. So, but the drug works well. And it was really established to work well for JIA uveitis by the Sycamore trial, which is a trial that was done. It was published in the New England Journal in 2017, and it was done by Professor Ramanat, who's a pediatric rheumatologist, and he did it with the National Health Service Network in the UK. And in this trial, they studied children who had JIA uveitis, and they were on methotrexate, and they still had persistent inflammation, and they were randomized to receive adalimumab or placebo. The trial was stopped early because the patients who got adalimumab did way better, right? They were better. And this really established that adalimumab works well and is an effective drug for JIA uveitis. So that's great, right? We have a drug that works well for our patients. But now so we are using it a lot. But now this is the question that comes up all the time in clinic is, okay, my disease is really well controlled. My arthritis and my uveitis, I've been on it for many years. This is, this is a juvenile condition. Isn't it? Can't I get off? They want to stop. Naturally want to stop adalimumab. Why do they want to stop? Well, I showed you it was expensive. It's an injectable drug, so there's a burden. There's risks with biologics, right? There's infection risk of other adverse events, and there's an inherent desire to want to be off the medications, especially in kids. So what happens when you stop treatment? Well, we had no data. That was the problem. Again, in uveitis, we just had no information. There was no trials. And if you look, why is it a big deal to stop? Well, there's a lot of fear actually with when you stop a monoclonal antibody, that you take a drug holiday, that you can develop antibodies against the drug. And then if you need to restart, the drug's no longer effective. And this is from a Facebook page. A colleague shared this with me. It's all been anonymized, but it's parents of children with JIA uveitis. And you can just see how much worry there is and anxiety about stopping drug, because these quotes are saying the experience of, I stopped drug and then I flared, the child flared, and then they restarted and they could not get back under control. So then they've lost efficacy with the drug, which is a big. So what do the guidelines say? Well, this is the issue with JIA uveitis. We still have guidelines, even though there's really wasn't evidence informing the guidelines, or very little evidence. The European guidelines say that you can try to stop therapy after 2 years of inactive disease. You can try to get off of immunosuppression in JIA uveitis. The American College of Rheumatology, and this is not old, this was in 2019, also said that if you have 2 years of well-controlled disease in JIA uveitis, you can try to get off of therapy. But what was that really based on? There wasn't data really. It was just kind of based on, thinking of people in the field. And moreover, after that, in the UK, adalimumab was being used a lot, but the National Health Service said, you can see down here that basically if you're doing well on it, you have to try to withdraw treatment at 18 months because it's an expensive drug. So they were trying to force people to try to stop drug. And so I saw an opportunity, we need to study this because we're anecdotally seeing a lot of flare-ups when we try to stop. Sometimes it works, but it doesn't seem like 2 years really working that well. And so I approached the UK folks, the ones who had done the Sycamore trial and Professor Ramanan, and said, look, like you did this great trial. You have this guideline that you have to try to stop. We're seeing this. Can we partner together to do this trial? And they were up for it. And this is the thing is like, I just think the power of reaching out across to other people who have similar interests and working together just makes us able to do these kinds of studies. And so we got able to get grant funding from NIH to do ADJUST, which is adalimumab in juvenile idiopathic arthritis associated uveitis stopping trial. And it's a stopping trial. It's patients who are doing really well on adalimumab. Their arthritis is controlled, their uveitis is controlled. It's really looking at what happens if you stop versus continue. What is the time to recurrence of eye and joint inflammation? And then secondly, if you flare up, if you stop, are you able to regain control, right? There's this fear that you're going to lose efficacy if you stop a drug. Are you able to regain control if you restart? It's a practical question I think that everybody would want to know. So we did a block randomized double masked trial. The drug was donated by AbbVie, although it was fully NIH funded. But we did have drug donated so that we could do a placebo control. So patients, they were already used to taking injections, but in this trial, half of them took placebo injections and then half took active. And so we followed them very closely because there was a lot of concern about recurrence and damage that could happen to the eyes. Remember that this inflammation is silent. It's dangerous, but patients can't feel it when they're getting inflamed. So you have to follow very closely. And our outcome was time to treatment failure. Treatment failure was recurrence of eye inflammation and had to meet criteria or severe joint inflammation. And we followed patients for a year. So, you remember for the FAST trial, we got that message saying we couldn't enroll in India. So this trial was starting in 2020. And first we got this email. We were just starting. We enrolled a patient actually at Children's Hospital, Philadelphia. And this was not a big deal. I was like, okay, fine, let's enroll. We just enrolled. We gave the go ahead to enrollment. There were no holds. This email from UCSF was like, well, this new virus, there's 2 patients. You don't need to wear masks. It's not as bad as the flu. Like you can read all this stuff. It's going to be low mortality. You don't have to do anything special. That's basically what it says in summary, right? And then a month later, different story. It's like everything is shut down. You cannot do research. You cannot do anything unless it's absolutely essentially, related to COVID-19 research. You cannot. And so we were shut down again. another kind of obstacle. But as so many people obviously were affected, it wasn't just us. But so it was a hard trial to enroll for. But eventually, everyone, all of our centers in the U.S., we had centers all across the U.S. and UK. We had 20 centers, and one in Australia were able to resume whenever they were able to. But it was really challenging because there were spikes in COVID, and in the NHS, the nurses would get deployed, the doctors would get deployed. They couldn't be taking care of eye patients anymore. Crazy times, but we tried and we did a lot remotely. We couldn't travel everywhere. It taught me a lot about how to do things in a different model. And we had a planned interim analysis. It was when we reached a certain number of treatment failures in February 2024. We had 87 patients at that point. And you can see we had a hard time enrolling, but we were getting there and picking up after the pandemic sort of let up a bit. But what happened at the interim, so at the interim analysis, you can see we had 87 patients. Across the red is the UK, lots of NHS sites, and across the US, lots of hospitals, including here and then in Australia. The DSMC, the Data Safety Monitoring Committee, said, we're going to unmask you and you should not enroll any more patients in this trial. You've answered the question with who you've enrolled, but you should continue follow-up for the year. You can still follow the patients who've been enrolled. It's safe to do that, but because you're following them very closely and they've already been enrolled, but more patients. And they said, publish your results. And so this was kind of unplanned. We thought we were going to go a little bit longer, but we ended up publishing our interim analysis results in the Lancet a year ago. And you'll probably see why it was, why we stopped. But we had 87 patients, and just to maybe highlight a few characteristics, mostly female because that's who gets JIA and JIA uveitis. The median age was 12. Kids that had disease for a long time. The median age of JIA, the arthritis, was age 3, and then they developed uveitis at age 5. And they had been on adalimumab for about 3.5 years as a median, so a long time. And let's get right to what we found. So what do we find? Well, you can predict, I already told you that the agency stopped the trial, but they stopped the trial because this is showing our primary outcome analysis, which is time to treatment failure. And the red is patients who are getting placebo injections, and the blue is getting active drug, adalimumab. And there's just a huge difference in treatment failure. With we had 14% of patients in the adalimumab group, and basically almost 70% of patients in the placebo group experienced treatment failure. And time to treatment failure when you stop drug was 119 days, so it took a few months. And so, yeah, for our primary outcome analysis, this translates to a hazard ratio of almost 9. So you are ninefold, increased risk of treatment failing, of having a recurrence if you stop drug compared to if you continue. And country didn't matter. It wasn't protective if you were on methotrexate or some other drug. We stratified for that. Basically, not really successfully able to stop drug in 30% of patients. Most patients flared up. They had treatment failure because of eye inflammation, some because of joint inflammation. And the next part is, okay, we had huge failure rates, way higher than we predicted, way higher. And some of our patients were on it, for years. They'd been controlled for well over 2 years. That was not protective by any means. But fortunately, they were able to regain control of inflammation within 105 days or so. And so that was reassuring. And all patients who had treatment failure were able to regain control of inflammation. That's not at any cost, though. I mean, not without cost, because you have recurrence of inflammation, you have to be on steroids again. And we're currently looking at that with our current fellow, Chris Rosenberg, who's right here, looking because some patients had to be on steroids and, developed high pressure and other issues. And we're looking at a lot of other things now, because now all the follow-up is done of this trial, and we're seeing differences by age, by pubertal stage, by Tanner stage, and we're trying to really look into understanding more about who's able to get off. Is it an age thing? Is it a puberty stage? And so hopefully we'll have more information about it. And then the big worry that I mentioned was, do you develop antibodies when you stop drug? And we did find, so adalimumab levels, of course, down when you stop drug, you can see that. But if you look at 12 months in patients who restarted on the right here, the drug level's right back up to baseline. So we're able to regain the drug level. And similarly, antibodies also went up when you stopped drug, but they went down when you restarted. So this was all very reassuring that you can do this safely. You can try to stop, but there's a really high failure rate, but we're able to regain control. And so, I think in summary for this trial, really inordinately high, disappointing. This is not what we expected for this to be this high. It's really, really high. 2 years of remission that all the guidelines say does not appear to be sufficient. I think it's falsely reassuring that you can try to stop at 2 years. It's a little bit of a personal choice about trying to stop, because some people can get off, but I think given the high rate of recurrence, really close follow-up is really important. And you can regain control. But again, we were in a trial setting where we caught the inflammation really early and restarted right away. Age may be important. We're looking into that now. And Thuy Do-an, who's here, is going to look at all the microbiome from the stool and blood and try to figure out maybe some of the predictors of recurrence. So now, our plans, we're thinking about what to do next. It's really hard to stop drug, but it would be a benefit if we're able to, if we're able to reduce drug, even if patients can take it less often. And so we're thinking about, we applied to the NIH and we got a great score on a new trial. We've been told that they want to fund us, that we're on the list to be funded, but the government has not released funding yet to NIH, as you all know. NIH, the budget's been passed, but they actually haven't received funds. So we're waiting to see what happens, whether that happens. But we are looking to do a reduced frequency, multiple different reduced frequency dosings to try to see if that's going to be a better strategy and do more precision medicine with drug level targets, actually. So targeting specific drug levels and doing therapeutic drug monitoring as a different strategy for this condition. So I just want to thank, I have an amazing, all of our international investigators and my Proctor team, they're all here. Ali, Sydney, and then our study coordinators, Catherine and Elia, and Ben Arnold, who's a primary biostatistician, who's here for this trial. And Sarah Lopez, who is our head optometrist, who did all the visual acuity training as well, and Jeremy and Thuy. Everyone made this possible. Okay, I'm going to just shift in the last little bit. to just talk about something else, about a different area of my research, which is doing observational studies, big data research. And, I'm a trialist. That was what my K grant was on. I love trials. I think it's the gold standard for studies. You cannot do trials on everything. They're expensive. They take a long time. And inherently, we want to be able to answer more questions, right? There's a lot of questions out there, especially for rare diseases. And so one that I was very interested in was herpes zoster. And so early on in my career, even though I was doing trials, I was building my skill set in big data research just by doing small studies, using UCSF data, partnering with Kaiser, trying to build my team to be able to do this kind of work. And eventually we were able to, also get NIH funding, R01 funding. And I wanted to study this condition called herpes zoster or shingles. Now, this is not an unusual condition. I'm sure everyone knows this, unlike uveitis, because it affects 1 in 3 people during their lifetime. But we care about it a lot in ophthalmology because it can reactivate the shingles, which is reactivation of the chickenpox virus, can happen in the eye. And that can be very devastating and cause blindness. This is a picture of what HZO or herpes zoster ophthalmicus looks when it reactivates along the V1 distribution, the ophthalmic branch of the trigeminal nerve, and you see all these vesicles on the skin. But it can also go into the eye and affect the cornea. This is PCR positive if you were to scrape the cornea. Scleritis, uveitis, retinal necrosis. This is the retina, basically the virus literally eating up the retina. So very devastating in terms of this disease in the eye. So we care a lot about it, and I see patients with this. I think it's a very fascinating condition that is still evolving, and we don't fully understand in terms of the epidemiology. So this is a study from Olmsted County from 2016, and they've been looking at the incidence of herpes zoster over decades, and it's been going up. And lots of studies have shown that it's going up over time. Nobody really knows why. Is it that we're diagnosing more? Patients are going in more? Are we better at diagnosis? It's not a hard condition to diagnose. Nobody really knows. Is it that patients are more immunocompromised? Is there something else going on? We don't really know, but it is interesting. And then there's been a lot of school center studies, including from Harvard, saying that, we're noticing that patients are getting younger, that we're seeing patients with eye disease from shingles where they're younger and younger. We used to think of this as like an over 60-year-old disease, right? Mostly, but now we're seeing patients in the 40s and 50s who are having it. Is it really going down? Well, you can't judge, right? Just from single center data. You really got to look at this at a population level. And so I, applied to get this grant to really use large data sources to look at the epidemiology of herpes zoster ophthalmicus, and the impact of vaccination. Travis, who you saw in the FAST trial, and Ben have worked on this with me and are great collaborators because they have amazing causal inference modeling skills and elevate our research by, basically there's limitations with observational data, but we try as best as possible to apply rigorous methods, and they've helped me to kind of learn what I have and to be able to apply it to kind of do the most rigorous work we can. And then many, many different analysts and on the top, and then students. All of these are all UCSF medical students who have worked with me over the years, and 2 new analysts who just joined recently. And so, not everyone's here, but over the last number of years, all of these people have made this research possible. Okay, so what can we do with herpes zoster? The reason why it's also interesting is that there's vaccines that have been developed now to try to prevent it, including there's an older vaccine, zoster vaccine, live in 2006. That's no longer on the market because there's a better vaccine called the recombinant zoster vaccine, or Shingrix, that came out basically in 2018. And it's FDA approved for 50 and above. It's not a live vaccine. It requires 2 shots, 2 to 6 months apart. It's very effective. From the randomized trial that led to approval, it's incredibly, it's in the 90% effectiveness range, or efficacy range. That's great for a vaccine, right? The older vaccine was only 50% effective. So the CDC says everyone 50 years and older should get this herpes zoster vaccine, whether or not they report a prior episode of herpes zoster. Even if you've had herpes zoster, even if you've had the older vaccine, you should still get this. Just to note, the trials that led to approval did not allow people who already had herpes zoster. You could not have a history of herpes zoster, but the recommendations are that everyone should get it, even if you've had a history. And so given that all these vaccines are there, it's like, okay, it's interesting to study the epidemiology. Is it changing? And one of the concerns is that, you have a chickenpox vaccine that's now available since the 90s, the mid 90s. So there's less chickenpox in the world, right? There's less, at least in the United States. Some countries don't have this chickenpox vaccine, but in the United States, chickenpox has gone way down. And so you're not getting this immune boosting, right? In the community, you're not around people who have chickenpox anymore. And you're not eligible for the zoster vaccine until age 50. And so one of the theoretical concerns is that as you lose immunity from chickenpox, or your vaccine as you get older, or your native chickenpox that you had as a child, you're not getting immune boosted. Are you going to be at risk for getting herpes zoster at a younger age? And so we've looked at it both for herpes zoster and herpes zoster ophthalmicus, and we did this using claims data, insurance claims data, large data through millions and millions of patients. And we are finding that it's decreasing both for zoster and zoster ophthalmicus in the old groups, and in the very young groups who are getting vaccinated against chickenpox. But it actually is going up in the so-called middle age groups and the 30 and 40-year-olds who are not eligible for vaccination yet. For zoster vaccination, we're seeing a trend going up. And so this is something I think that needs to be followed up. And we've also looked at how effective it is for preventing zoster in the eye. Trials don't report anything about zoster ophthalmicus. They just say preventing zoster, but they never look at the eyes. And so we care about that as ophthalmologists. So this again was 4.5 million patients in our cohort. And we found that if you get vaccinated, and we did a lot of causal inference modeling here, but basically the incidence rate, if you're vaccinated, is 25.5 per 100,000 person years versus if you don't, 77. So huge difference. And when we look at an adjusted vaccine effectiveness, really accounting for all other medical conditions, drugs, comorbidities, you name it, we have very high adjusted vaccine effectiveness for preventing herpes zoster ophthalmicus with this vaccine. It's in the high, basically close to 90% in all age groups. This is in real world data. So this is a very effective vaccine. And as ophthalmologists, I think we really want to try to promote vaccination in our patients to prevent this very devastating disease. Okay, so then one of the questions, something that then comes up all the time in the clinic, again, this drives our research, is remember I said that the recommendations are that even if you have zoster, and that includes zoster ophthalmicus, you should get vaccinated. But that's never been studied. That wasn't studied in trials. And anecdotally, and also case reports, ophthalmologists were reporting that they're seeing patients having increased eye inflammation. So patients who already have zoster in the eye and then get vaccinated with the zoster vaccination, they were seeing increased inflammation post-vaccination. And this was a concern. And we did surveys of the field, and there was hesitancy among doctors to recommend it, not because they're against vaccines, but because there was a lack of data in the population that already had HCO in the eye. They were seeing this in their practice, and there was no data on this at all. And I would get emails like, should I get vaccinated? And we didn't know. We would see sometimes, increased inflammation, but we didn't know. So what is the issue with this? Should they get vaccinated or not? Well, there's this whole balance, right? Of the virus is, so patients who've already had it, the virus, we know that HZO can cause chronic recurrent eye inflammation. It's unique because the eye is a unique site. Unlike the body, you don't usually get recurrent zoster on the skin. You can have it in the eye, and it's PCR proven. It's on the cornea, and sometimes it's not infectious, but just inflammation. Maybe it's a reaction or an immune reaction to viral antigens that are still around. But you can see this up and down inflammation. So it's this balance between the virus and the immune system, and we didn't know what happened to get vaccinated. So we looked at this question in 2024, and it's the first look at it. And we looked at patients who had zoster ophthalmicus and then got vaccinated or didn't get vaccinated, again, trying to adjust a lot of things. And we did find that there was a little bit of a higher risk, actually, in the 28 and 42 days in the immediate post-vaccination period, if you got vaccinated, with a increased inflammation in the eyes requiring medication adjustment. And we required visits with an ophthalmologist and increase in medications to count as a recurrence. So this gave us a little bit of pause, and we are trying to look into this further now and identifying the subgroup of patients maybe that's driving it that have the highest risk. We don't want to come out and say that patients shouldn't get vaccinated. We have to be very cautious about this. But this is why we do these kinds of studies, is to kind of be able to provide more recommendations for specific groups of patients, acknowledging that sometimes general recommendations may not apply to everyone. This paper, I'm an eye inflammation researcher. We don't get in the press, in the media, right? We just don't. That's not the kind of work we do. It's not like it's press worthy. It's for the field. But somehow when we published that the shingles vaccine may increase risk of this, somehow the Epoch Times, you can look it up if you don't know what that publication is, but they like loved that, right? And so I should have had, this was in 2024 before all the madness happened, but I should have had a sense like vaccines are a loaded issue. I didn't really realize that. I guess I knew from COVID, but I didn't really think that our research would be loaded. Okay, so then we've continued to look at vaccines. There's this whole thing about vaccines may have off-target benefits. And there's been a lot of work with dementia and herpes zoster. And our paper was actually one of the first papers looking at recombinant zoster vaccine and the risk of dementia. We published this last year, and there's been a lot of papers that come out since then, all not trial data, but basically this is, large data, 4.5 million patients. And basically showing what we've been able to show is that if you get vaccinated, partial or even fully is even better. You reduce your risk of dementia. It's associated with a reduced risk of dementia. It's not causal. And if you have herpes zoster, you're going to have an increased risk. So getting zoster, it's a neuroinflammatory condition, we think, increases your risk of dementia. Vaccination decreases it. And if you have antivirals, that also decreases it. And as you get older, of course, you have a higher risk of dementia as well. But this is, if you adjust for everything, vaccination seems to be a very potent, like a 32% reduction in dementia risk. And that estimate that we found now has been replicated by multiple groups and different data sources, like the exact same estimate. So it's kind of interesting, even though it's still an association, it's been replicated many times. So, we're continuing on this journey with zoster. It's still a journey. There's still a lot of questions. It's not causal, right? It's association. So we have to kind of do our due diligence to go deeper in the data, understand what's driving these associations. And we're trying to look more into the vaccination issue for both dementia and recurrence in patients who have HZO. But I want to just finish up last minutes here with this. And so Jackie talked about this a little bit, but again, I said, like, we work to do this for our patients, for our scientific field, and we don't really engage with the media that much in my field. But a year ago, like this is basically exactly a year ago, right? March 11th, I was in clinic actually, and I got an email from this Washington Post reporter saying that my grant was terminated, and I hadn't even heard from UCSF yet. I hadn't, because they know everything. I don't know how the reporters know everything, but they do. And I was in clinic and I got this, and then I was writing like grants management, like what's going on, like what's happening. I had no inclination that this was going to happen. And then UCSF had gotten notice, but it hadn't gotten to me yet, because when they got, it was probably one of the first terminations they had gotten here, actually, is what I was told, the first. And it was the first for NEI too. It was like it might've been one of the first terminations out of NIH. They didn't want to just send it to me. I think it went up the ladder all the way to, I saw that, to vice chancellor. And then finally they were like, I saw him there, like saying, Nisha's asking, like reporters are telling her, can we tell her that she's terminated? So I said, I already know. I found out from the press. Can you just tell me what happened? But in any case, I got terminated for vaccine hesitancy research. But as you already saw in my research, it was because I was saying that doctors were hesitant to make recommendations because they didn't have data. It was kind of a crazy thing in my, in the searchable abstract, I have the word hesitancy and I have the word vaccine. So I think I got caught in that. And I am not somebody who's interacted with the media, but yes, I did not go to the media, a single media source. They all said they were going to write about it on their own, and I could either participate or not. So I did talk to them but it was kind of a weird thing, because this was just all for months. The story kept on propagating. I think they just saw it as an example of kind of craziness happening. And so there were tons of, even in India, I don't even know, like Indian American, like I was born in America, and I don't even, like they were publishing on it, and in Switzerland and other countries. It was kind of interesting. And there's more than this, but it was, really kind of a crazy experience for me. I was not sure if this was the right thing. I talked to Hal Collard, and he's like, you know what, stand up for science if you want to, but obviously there could be ramifications. We don't know, repercussions. But he was very, very, and I got a lot of, I'm not going to read these. I got a lot of nasty emails from crazy people telling me that it's good my grant funding was canceled and that, I don't even do autism research. I don't even understand. These are older people. This vaccine is for 50 and above. So how does this have to do anything with autism? But I'm going to just say Bob Wachter was CC'd on a lot of my emails, and I had to apologize to him. And he's like, oh no, I'm sorry. This is my life. This is what I suffered through all of COVID. And so he was really supportive as well. So what have I learned? Okay. This is not what I've learned. So don't drink better, but this is actually a good phrase. What have I learned through this process? I did wallow in like self-pity and feeling bad for a while. Yes, I did. And I think Tom Liebman was like, well, you can do that, but you need to move on. You need to move on. You need to move on and do something else. So I actually resubmitted the R1, like modifying it and, putting in things, even though I was wallowing in self-pity, but it's like, just keep on going. Like, don't just be bitter and just stay there. Like, don't get stuck, right? Keep on going. But I actually appealed directly to the government, and it took them, they didn't even respond to UCSF. No email, didn't even say they received it for like 6 months. And then they sent a full grant back. Like, I got it back fully. We also were in the court system too, and it would have probably gotten restored that way, but really they did read everything. And so I don't know. I am grateful that that happened, but it was an experience. And so finally, I just want to acknowledge, my patients are what's driven all the work, all the trainees that have done so much work and continue to keep me on my toes and to question and be curious. My faculty colleagues who are really made all of this possible too, because you can't do this kind of stuff alone. Our wonderful clinic staff, my research group, Office of Sponsored Research. And I'm going to put Kat Chan there because she's the grants management specialist and handles all the day-to-day operations. And it's like a very thankless job, but it's so dedicated. Even the NEI and NIH know how dedicated our grants management people are here, and they say they're better than any other university. Stephanie Young's on Post Award, and then all the funding agencies, National Eye Institute, Research to Prevent Blindness, and All May See Foundation. And I've just learned that you can't do research alone. You want to trust people and be generous and work with people. And you're more powerful if you take that attitude and build networks, reach out to people across the world. Your patients are more representative. Your research is more generalizable. That's my philosophy. Trainees add to the research, everyone kind of adds. And I'm so grateful that I've been able to do that kind of work throughout my career and to continue. So thank you very much. Oh, thank you. Yeah, wherever you want. I don't know. Yeah.
Yeah.
And Tom.
You got your hold it.
I know.
I think that's the right way.
Yeah, thank you.
While we're doing this, I just want to thank Nisha for an incredible lecture. That was demonstrating her impactful, impassioned, what a story of resilience and grit to like make a difference in how we take care of patients. Let's just hear for Nisha one more time. That was awesome. Great. So thank you to the Academic Senate. Thank you to Dan. Thank you to Tom. And thank you, Nisha, for pushing forward in the context of incredible adversity to continue to pursue science and truth and make a difference for our patients.
I'm very lucky and grateful. I mean, so many of our colleagues have not been as lucky. And so I think it's just a reminder that we have to all keep on going and doing what we can in this part, in this journey, right? Thank you. I'm happy to answer any questions in the last couple minutes before the reception, I think. Oh, sure. Okay. Yeah. What is the Zoom question? Yes, please. Mm-hmm. Uveitis. Yeah, so there is some failure rate over time, but you saw that we had a pretty low failure rate. It was only 14%. Those patients had been on it for many years. There is some development of antibodies. Just because you develop antibodies doesn't mean that it's enough to overcome having a decent drug level. It's a balance between the level of antibodies and the drug level. But we do follow it in patients, and there is a thought about, especially inflammatory bowel disease, they have target levels of adalimumab where they routinely check drug levels and antibody levels. And if the drug level is low, even if they have antibodies, they push up the drug dosing to try to overcome that. Sometimes it's not possible. And even if you escalate, give it weekly or give it more often, you still have a low drug level and have high antibodies. Then we move on to other TNF alpha inhibitors or other biologics. But there is a strategy. We don't have therapeutic target for uveitis. We don't have what IBD does or what rheumatoid has. And that's one of the goals for the next grant, is to be able to do a treat to target type of scenario. Yes, Dr. Lewinsky. Yeah. Yeah.
Nice to learn that
Yeah.
we don't know the cause. You
We
mentioned that genetics might be involved. So
Yeah.
I wonder what we know about that. And then the other question is, in my world of neurology, paraneoplastic syndromes are associated
Yes.
with all sorts of, so is there any connection there?
Yes, both of those are. So the thing is, I think because uveitis is so yeah, the question is, what do we know about genetics? What do we know about paraneoplastic syndromes and uveitis? The thing is that uveitis is so heterogeneous. So there's certain uveitic conditions where, for example, HLA-B27 associated uveitis is heavily, it's a certain kind of recurrent anterior uveitis is heavily linked to being HLA-B27 positive. Or there's a specific kind of uveitis called birdshot chorioretinopathy where you're HLA-A29 positive. But it's not just having that HLA type alone is not enough, right? So there's probably the thought is, for example, with B27, is that it predisposes you to, when you have infections, maybe gastrointestinal infections, that there's then subsequently an immune mimicry going on, with the HLA type, and then post-infectious type of stuff going on where you have immune mimicry where unfortunately, it loses tolerance of the eye. But there's all the other types of uveitis. We don't know anything about it genetically. There's not like a gene that's been identified when you do genomic gene-wide testing or anything like that. It's probably multiple genes that maybe increase susceptibility. There's some type of studies like that, but honestly, it hasn't been that widely studied. So right now we don't have, there's certain conditions that we know, like Blau syndrome, that are not to mutations. There's a few uveitic syndromes where there's a genetic basis, but for most of them, there's no knowledge. There may be multiple genes that we just don't know. We just don't know. Paraneoplastic can happen, right? So we do think about this. There's when patients have, this is something we see actually in clinic quite a bit, is you can have this autoimmune retinopathy where if you have cancer in the body, even if it's in remission, and you could have a little recurrence of a node, and you can basically get this paraneoplastic process where, tumor-related antigens are targeting the retina. You can measure those. You can measure them. You can measure anti-retinal antibodies. Some of them are associated with cancer. When we see this kind of condition in the eye, and we see a progression of vision loss and a loss of retinal function that's pretty rapid, and it doesn't fit kind of what we typically see in regular autoimmune situations, we actually get PET CT scans, and we find it. We just had a patient that I saw who had a little remission for ovarian cancer, and we found a little foci on a node, and it was positive. It was a recurrence, and just because of the eye. So yeah, so we do have to kind of, to your point of, this is why I like our field, because we think about everything going on in the body. Yeah.
Thank you.
Thank you. Yeah.
You're freaking hour.